All right. Good morning, everyone. Welcome to another webinar Wednesday here at QLI. I've got Steve Kershke with me in Studio Q. And today we're going to be talking about effective treatment of limb loss. So I'm sure a few of you are familiar with my voice and Steve's, but if not, welcome to your first podcast webinar. I'm doing a podcast later today, so I'm just in the
Those
just
are usually
roll.
better than webinars.
That's
anyways.
true, very true. But we appreciate you joining us. For those of you that don't know, QLI, we are a post-acute rehab provider located in Omaha, Nebraska. And we're going to tell you, like I said, a little bit about limb loss today. So before we get rolling, as always, there is going to be a poll question towards the end. So if you are wanting to receive a certificate of completion, please make sure you stick around and answer that later on. And then, as always, let's make it conversational. So there is a chat function as well as a question and answer. So Steve and I both really enjoy when there's more people to talk to than just ourselves staring at each other across the way in the studio. So Steve, for the audience members that don't know a little bit about you, if you could do a quick little introduction, tell us about your career here, and then what you're currently doing, which is a lot. You wear a lot of hats around here. So
Sure. Well, physical therapist by trade, started at QLI in 2005. And if Don Terry's on, I always talk about there was a little bit of time here where I got a little lost, left QLI for a few years, and found my way back into a marketing role. So somehow a clinician in a marketing role fits, and work really closely with you on our work comp marketing efforts, which is really fun to travel country and build relationships with individuals in the work comp space. And then more recently, over the past 3 years, have had the opportunity to work on our tele-rehab service and programs. So that's been a really fun project and some great challenges, and really the expertise of our clinicians that I get to work with and the outcomes that we've achieved has really blown me away. So
well, I would say that there's not very many people that hold it against you that you left, because we're glad you came back. So but on the tele-rehab side, I know some folks on this webinar may be familiar, but you guys have some exciting things going on over there. And so I don't know if you could briefly share a little bit about a rebranding effort, and tell them kind of a little bit about that exciting news.
You bet. Well, I'll put the marketing check in the mail. I know we usually try not to do too much of this, but for those of you who are familiar with our QLI tele-rehab services, really the only thing that changes is a new name and new brand. Still the same expertise, still under the same roof here at QLI. We're fortunate to be backed by QLI's corporate structure, but we are a separate entity, and over the past 3 years have really developed a little bit of our own identity, and that's what was the impetus for creating a new name and a new brand. So it's pronounced Continue. We're doing better at helping people understand how to pronounce it, but really it's a play on the word kin and this idea of family and togetherness and community, as well as kinesthetics, which is the science of movement. So we really want to help folks move forward. So we're pretty proud of what we came up with, and certainly proud to still be part of the QLI community, which is really important to us too.
Yeah, and I think something you said there is important, that being a part of that community means you guys still have some of the best clinicians.
Absolutely. Yeah. All of our clinicians came from our inpatient program. So I have kind of a bad rap around here for that too.
Let's say if there's anything anyone holds against you, it's the fact that you're stealing clinicians.
Yeah,
often, right? So
ended up with some really good clinicians, but thankfully we're pretty deep in other areas. So I've made up for it, hopefully.
Well, perfect. Well, I appreciate you sharing that with the audience. Absolutely. And hopefully some of you've already seen some of the e-blast we've sent out with that exciting news, but if you haven't, now you heard it straight from the source. So all right, well, I think we should get rolling into the presentation. Before we get started though, Steve and I were chatting beforehand, and we just are curious how many people on today have experience with helping someone go through a limb loss recovery journey, and have had experience managing these types of claims, or had one of these individuals as your patient. So if you could in the chat, go ahead and just let us know. We love knowing exactly how many people have experience with these types of things. It helps us maybe shape the conversation a little bit, as well as it gives us some names to call out later on when no, I'm kidding, we won't call you out, but we do appreciate you letting us know. So and with that, Steve, I'll go ahead and let you kind of go with it. So
lots of familiar faces out there. Tim, I was just thinking it would be really fun one day if we had everyone change their name to like a fun screen name, but then we wouldn't know who they are. So nice to see some familiar names. Looks like quite a few folks are weighing in, with several patients, a couple folks who maybe don't. So really, hopefully we give you some new information today. But also happy to talk more about, the transitions through each part of the recovery process, even some, details. Certainly they'll be anecdotal to how we handle things at QLI, but hopefully it transfers to some of your experiences, and use the chat function for some of those particular ones. Those are answering questions is really what makes this fun. So
absolutely,
please weigh in.
Yep, please question, answer, chat. I'll be monitoring it and appropriately interrupting Steve along the way if there's something that is timely. So
sure. Well, as many of you know, QLI is a center of excellence model, and so when we talk about limb loss, we certainly take that approach. And so we believe that effective treatment of limb loss can be done using a center of excellence model from start to finish. And so that's something that we feel pretty strongly about. And because of limb loss being so complex, really it falls in the same category as what we do with, TBI, spinal cord injury, chronic pain. The complexities anywhere from some of the physical deficits that happen all the way to some of the psychosocial and emotional aspects of recovery. Putting that all together can be really challenging. And certainly it varies depending on the injury and the person. But from start to finish, a center of excellence model is a really nice approach. So if you are listening and you are managing many of these cases, I would strongly encourage, after an injury, utilizing the acute rehab hospital for center of excellence approach, and then transitioning it on down. So here's kind of why we feel that's important. First and foremost, there's some cost that can be saved. Along the way, there's many decisions that need to be made in terms of recovery. So anything related to medications, management of the limb, any surgeries that need to happen, sometimes that can be a tricky decision. Obviously, for the person who's injured, first and foremost, they want to save that limb. Sometimes that's possible, sometimes it's not, but many times it's not a slam dunk either way. There's a lot of decisions and a lot of variables that go into that decision. So, and then lastly, in terms of cost, is the prosthetic limb, if and when that happens. Nowadays, there's everything from, a basic prosthetic limb all the way to some limbs that have quite a bit of technology in them. And they can certainly be indicated, but the last thing we want to do is get someone a prosthetic that sits on the shelf and collects dust. And unfortunately, that happens quite a bit. So using experts along the way can help navigate a lot of those challenges, make some decisions, prolong some decisions when it makes sense. And that kind of leads into the clinical decision making. So certainly the surgeon, especially out of the gate, in terms of planning, trying to make sure that person has a residual limb that's pretty usable, and that then it's a collaborative process with a clinical team, including oftentimes a physical therapist or an occupational therapist, and then a prosthetist who hopefully has quite a bit of experience with things like this. And so the sooner that those few disciplines and more can collaborate, I think the decision making goes up, and we can start to look down the line and project maybe where there's going to be some high points and potentially where there's some red flags. And then all of that transitions into just managing the intricacies of complex cases. So we're talking a lot about the medical aspects of someone's recovery. But as I mentioned, there's certainly more to it than that. It's the psychosocial, the emotional aspects that come with it. And how do you put all that together and get someone back to life? And so helping them understand that, life does go on. You can actually have a really fulfilling life, even though it might look a little bit different. And for many folks, either helping them learn new emotional coping and strategies for resilience, or tap into some of those skills that they've already developed over the course of their life. That can be really challenging too, and certainly we cope in many different ways. And so that center of excellence really starts to look at this holistically from start to finish. When we see situations go awry, it's because maybe they had a provider that was less experienced, didn't really understand the nuances of what's going on, and maybe not as capable of predicting some of the challenges that are going to be coming down the road. The other thing that we talk quite a bit about is this idea that all of our therapy should be connected to our life, right? And so when we do that, it brings a meaningful, individualized, and engaging therapy all along the way. And so if anyone has heard us talk a little bit about our approach here at QLI, we really look at it from three positions. The first being folks have to be medically stable. And those are all the things that we just talked about. Are they on the right medications? Is the residual limb properly cared for and prepared for a prosthetic if that's the direction that we're going? And then do we make the right selection in terms of the prosthetic? But beyond that, there's a ton of therapy that goes with that. And and like I said, that's physical therapy, occupational therapy, psychotherapy, and even more. And that therapy must be tailored to wherever that person is going beyond rehab. And that could be back to work, back to some leisure activities, some fitness activities, even sports. And no matter how we approach that, there's always going to be a gap. But the really good providers really narrow that gap and make sure there's as few surprises as possible once that person really reintegrates back into the real world. And so that should be a big part of any program. And it's actually, I think, the secret sauce to any provider who can do it well, because it takes a lot of creativity, takes a lot of hard work. You got to really think outside the box and really do some things outside of a brick and mortar formal clinic setting. All right, so now we're going to get into the phases of recovery. So we'll talk a little bit about the key aspects to each phase. There's 4 in our mind, but all along the way, there's some really keys to the recovery, as well as some areas to just keep an eye out for. The first one is phase 1, where this involves the acute rehab hospital. And so at the time when someone has an injury, oftentimes they're going in and they have some sort of acute hospitalization, right? So if it's a traumatic injury, especially, they're trying to become medically stable, oftentimes interacting with many different physicians, other medical providers. And if there is a need for surgery, there's quite a bit of planning that goes into that. So what might need to happen before the surgery, and then let's start to plan out what's going to happen after the surgery. So again, we're trying to look ahead, plan along the way, and really be proactive with everything that we do. So there should be hopefully a pretty well thought out rehabilitation plan. And depending on who's involved, right, that can include physicians, hopefully a prosthetist at this early stage if possible. If it's a work comp injury, hopefully a case manager and the work comp carrier team can be involved, depending on who that is. That can look quite a bit different. And then the other clinicians, certainly the family and the injured worker, if they are involved in that too. Right. But this is a spot where we can start to project, here's what you're going to go through. We don't know everything, but we can at least, start to educate on that. And then we can talk and help them understand how that's going to all play out and start to foreshadow things down the road. So that education component and the planning component of that becomes really key to someone's, I think, emotional state, and really the adjustment to life starts here. And at this point, it's extremely fresh, extremely raw. And so even if we had some sort of counseling and psychology provider accessible at this point, I think that really, really helps start to set someone up for some success. As I mentioned, doing that sooner rather than later, I think makes a really big impact. As we all know, when something catastrophic like this happens and someone starts to try to envision what their life looks like potentially with at least one instance of limb loss, potentially multiple, that can be pretty daunting. And so having a provider or a team of providers, especially who understand emotional coping and adjustment, who can feed off each other and really take advantage of some real-time opportunities to help this person process through what that might look like, and really then establish some good routines right out of the gate for this individual in terms of coping, making sure that they have a support network, and if they don't, what's the plan for that? But the sooner that we do that, those routines and those habits can start to be laid as a foundation for, really down the road, once they get out on their own, that's when they're really going to have to apply these skills. So when they go back to work, when they go back to school, when they go back to whatever they're doing further down the road after they've received a prosthetic, that's when you really see, the fruits of your labor at this point in time.
We just got a very excited yes in the chat, so I feel like someone
strongly
agrees with you there.
So I'm not. I'm at least on track a little bit, huh? Thank you, Sarah. So I can't stress the impact that this component can have. It's probably not a surprise to anyone, but with mental health and that being such a hot topic these days, I think it really can be something that is pretty impactful, especially when you have something catastrophic like this happen. All right. So phase 2. So let's just say at this point, after the acute hospitalization, there was a decision to go ahead with the surgery and prepare for the next step in the process. And so there's quite a bit of training that can be done at this point in time. There's certainly some medical management that needs to happen. And so depending on where the surgery takes place, there's going to be a wound likely, and some sort of pain management that can take place there too. And so along with that emotional and psychological component, pain management, I think, is something to really be on top of here too, right? So at a certain point, we definitely need to manage it in terms of the acute pain. But I can't tell you how many times we get someone coming through QLI several months or years down the road, and if pain wasn't managed well early, we start to have some associated issues that are popping up. And so not only are we dealing with the functional component of limb loss and the recovery from that, but then we end up having some additional medication management and some training in terms of chronic pain management, and that can be even more challenging than the actual limb loss issue. So up to this point, certainly they're going to be on some medications to help manage that acute pain, but the clinical team should be pretty aggressive in starting to set up what does that pain management look like way beyond that. It is very difficult. I'm seeing some aspects of this pop up in the chat too. I agree. There's certainly some situations where you can start to predict, yeah, this person might be someone who we have to watch that for. But absolutely, there's times where that can't be predicted. We've just been looking into some components of education in terms of what recovery should look like. And I was reminded, not to digress too much, but about our chronic pain program, Tim, and the idea that one of the first things that we do is educate people on pain and the mechanism of pain. And so there's quite a bit of research out there that if someone just understands pain and understands how it, why we have pain, how it impacts our functioning, and ways to cope with it, it can have a very positive impact down the road, and we can avoid lots of issues that can come up.
No, I think that's a good point. And I wanted to bring this up too. We had someone in the chat earlier mention that they had experience with managing one of these types of claims, and then also managing subsequent issues. And so I think in the chat, if someone, if we could get some participation from everyone on, what are some subsequent issues that have come along that maybe you as a clinician or as an adjuster or someone in the insurance space didn't know something that needed to be managed early on. I think that could be interesting to see some of those things. And I'm sure we can either touch on them if we don't already have a plan to, or I'm sure it's coming up in the presentation.
Yeah, it would be really great to see some of that. Excuse me. But while we're seeing some of that go through, one resource I just wanted to throw out there on the topic of pain. If you're familiar with the book called Explain Pain, I just stumbled upon a second version of it. It's Explain Pain Supercharged. So there are two different books by Lorimer Mosley and David Butler. They're really great resources for a couple reasons. One being educating clinicians and providers on understanding pain and how to actually explain it to a patient. And then beyond that, there's actually an associated workbook that helps the patient work through it with the provider. And so this idea that if providers can get good at explaining pain and helping people understand it, and then the patient can understand their pain and start to apply it, you get some really good results in terms of just the education that is involved here. All right, so let's just kind of see, we got some family dynamics popping up, skin breakdown, the wound management there, certainly a consideration.
Yeah.
What else you see there coming through? Pain.
Counseling with partners. I think that's kind of back to the family issues.
Mm-hmm.
Finding a PMR to take over care.
Mm-hmm.
We've talked about that, internally quite a bit. So wound care, mental health, that was something you mentioned early on.
Mm-hmm.
So those are some of the ones that
Yep.
popped up.
So yeah, on the wound care component, right, we can address that right out of the gate. So making sure that the wound is properly cared for, it's clean, it starts to heal, and then on top of that, starting to shape the residual limb in a way that it can be prepared for a prosthetic if that's the case. In terms of the PM&R involvement, I do think that's a really big key, right? Having some oversight into the management of the wound, the limb, but also pain, right? Like that's a really key provider to have on board, especially right out of the gate, so that we can manage that and we don't set people up for issues down the road. The other thing I just saw here is the prosthesis vendors and the turnaround time, right? So the sooner that we can start identifying that provider, the sooner that we can start laying out some of the options for a prosthetic, then we can start that decision-making process right out of the gate too. Because back to my initial thought in terms of prosthetic choice, exploring, what are going to be your goals when you go back? Are you going to be utilizing this for sports and things like that? Do you need some fine motor, or can you get by with maybe something that's more low tech?
Yeah, and Brenna brought up a good point too, just change in fit of the prosthetic when someone hasn't seen a provider in years.
Yep.
Kind of those early on questions lead to a better fitment
as
well.
Absolutely. So at this phase, right, we haven't got the prosthetic yet, but there's still some volatility, right? So that residual limbs are going to change size, might change some shape. We might deal with some swelling. So we have to get that in check before we can even consider a prosthetic, because if it's not, then the prosthetic fit is going to be a challenge from the start. So the sooner that you have a clinician, oftentimes OT and PT, depending on how the providers approach this. Like for us, our PTs don't just handle don't just handle lower extremity. They might be involved in an upper extremity situation, but having an OT who can help with independence and ADLs and start to prepare that person to just take care of themselves is a nice adjunct to everything else, right? So that could be positioning, right? Simply positioning could help with the shaping of the limb, the swelling that might happen, even some wound and pain management that happens there too. So there's lots of ways to tackle this, and looking at it from an interdisciplinary approach, I believe make sure that we have everything covered from all angles. So just, building strength and endurance, some of the independence components, right? So at this point, it's going to be, pretty well focused on compensatory approaches, right? So that person isn't going to have the prosthetic at this point. And so making sure that they can access their shower, get in and out of bed, some dressing techniques, and can they start to build the strength and endurance that they need in the residual limb, as well as other aspects of the body that are going to have to kind of pick up the slack for for the injured limb. So this kind of gets us through phase 2, and appreciate all the input on some of the challenges, and hopefully we'll address those down the road. If we don't, just kind of give us another ping. All right, so getting into phase 3, I think there's a couple different approaches for this. One thing that I didn't list on here is outpatient therapy, right? So our approach, and we believe that an intense, comprehensive inpatient or day program is a really nice option. Certainly with the fact that we are a center of excellence model, one of the biggest challenges we have is to get someone to sign up for that, right? So you're telling me I have to go to Omaha to get this care. That has been a challenge for us. And so I do think geography plays into this. I also think decision-making of providers and case managers around this impacts this too. I think for whatever reason, people see limb loss as maybe a bit less complex than something like a traumatic brain injury or spinal cord injury. So the need for an inpatient program, or even a pretty intensive day program, we found is a bit less palatable, but I think it's a really strong consideration. Certainly outpatient therapy could be an approach at this time, but there's a lot of volatility in what's going on right now, right? So the fit is something that is a big focus. You're working with prosthetists, and oftentimes if that prosthetist needs to make adjustments, it's going to affect the therapy. And so having those two, the prosthetist work with the clinical team very closely, we can move pretty quickly here too, right? So when I say inpatient day or day program or rehab program, I'm not thinking 6 months here. We're looking at 4-6 weeks ish, depending on the situation. And so you can move pretty quickly, and really investing that time up front when you have an intense program with a high level of interdisciplinary collaboration, we can avoid a lot of problems, and we can move really, really quickly. Certainly their physical recovery can impact some of this, so we want to make sure that the timing is right. But it definitely sets things up, and in the long run actually can save money and save time. So again, at this point, we're looking at making sure we have a good partnership with a prosthetist to identify the right prosthetic, to get the prosthetic, at least the first round of it. And then we're, depending on where that person is at, we're setting up a long-term relationship with the prosthetist, as well as the other rest of the clinical team. And we'll talk a little bit about how we envision that here, but that can be done in lots of ways too, right? So if there's a local prosthetist, hopefully there's a local clinician who's pretty familiar with dealing with these types of injuries, and those two can work pretty closely together. Ideally, if they're in the same office, that's even better. So locally here, we have a hanger clinic. It's newly a hanger clinic, but they really paved the way for this idea that having a clinician like a physical therapist in the office with a prosthetist can, again, help it move very, very quickly, right? So if an adjustment's made, what does the gait look like? If an adjustment's made, how are they, activating some of the shoulder stabilizers to make sure that this person is functional with an upper extremity prosthesis? So you can go back and forth, and you can avoid some office visits and things like that. So if you have that in your area, that's a really nice option.
I guess that would be my question too. Is there any guidance you can give for our listeners of like what questions they should be asking providers? Is it as simple as saying, hey, tell me the breakdown of how you guys interact with each other?
Yeah, I mean, I think understanding what does the communication look like, and is there any just ego and territorialism with that? Sometimes, even for us, like when we have to collaborate with prosthetists, sometimes they see it as us encroaching on their turf, right? So I can think of some people who've come through our program, and the prosthetist is back in California and is local, right? And so we have to call him and say, hey, tell us what you're seeing. And that can be a bit conflictual depending on how that prosthetist responds. And so finding clinicians who don't have big egos and who really just understand that a collaborative process isn't inspective in any way. It's really meant to be supportive. And for us, it was understanding, okay, like you have some great information here, and tell us some of the challenges that you saw. Here's what we're seeing, and now how do we find a way in the middle? Definitely understanding, what is their level of openness to collaboration with, in this case, maybe a different provider, But if it's a prosthetist and a physical therapist, making sure that they are going to be actively seeking input from each other, and being very transparent about what's going on, and being proactive about that too, understanding that when you make adjustments to the limb, or the fit of something or the socket, it's going to affect some things on the physical side. And if you don't address it very quickly, you do end up with things like skin issues and other pain areas, because maybe the gait is off from what you expected it to be. So that relationship, I think, is really, really important, and finding some trusted providers can be challenging, and finding prosthetists, especially, or even a therapist who understands the perspective of a work comp payer, right? Because I think that's a tricky situation too, when you start getting into recommending prosthetics for an injured worker, right? We all want to do what's right for the injured worker. I would love to get everyone multiple prosthetics if they ask for it, right? But there are definitely times where that doesn't make sense. Perhaps that person's not physically active enough, or they haven't shown that they're going to use it, right? And so we have to flush all of that out. And so back to this idea of an intense comprehensive program, you can start to put that person into lots of different scenarios, and you can make a pretty good prediction on, like, yeah, this person's probably not going to use this long term, or no, they've been really consistent from day one. Not that they're not going to have any bumps along the road, but we think that they're going to do a pretty good job of using it. And they've shown that they are interested in sports, and they're interested in getting back to running or hiking or whatever. And yeah, they might benefit from a different type of prosthetic to allow them to do that. And we know when we do that, that can affect emotional stability. It can affect long-term outcomes, and affect the buy-in, and really make sure that people are successful long-term. All right, Kelly, we have provided two, such as when one is very physically active and offer a running foot type. Yeah, so we see that quite a bit. Lots of payers are very open to that, but I think it's this skepticism of, yeah, we're open to it as long as it's going to be used, right? I can't tell you how many times it just gets frustrating when the payer's trying to do right and really be open to getting that person back to life, which does include running and lots of different things. And then they get burned. And so it's helping navigate those scenarios, because our experience has been the payers are generally pretty open to it. And as providers, it's our job to help with that and make sure that that payer doesn't get burnt as best we can. Certainly we can't do that all the time. Okay. Again, in phase 3 last, not to hit on this again, but I mean, you can't underestimate the importance of helping these individuals see a light at the end of the tunnel, and helping them understand that it's really healthy to have hope. It's really healthy to be optimistic about your outcome, and you absolutely can get back to lots of things that maybe you can't envision today. And to tie it back to the comprehensive approach here at QLI, we certainly have psychologists on board, and the psychologists are the quarterback of this aspect of the program, but all of our clinicians are really capitalizing on this. And so the amount of repetition that someone gets to re-envision what life is going to look like, to capitalize on certain strategies related to CBT or other cognitive behavioral therapy related strategies, to apply them when they leave, is extremely important. And the more repetition someone gets at practicing that, the better chance that they're going to actually do it on their own when they're out in the real world and they don't have the structure and the support of multiple clinicians. And so now is a really good time to start building those habits, or having that person reinvest in some of those habits if they happen to have them prior to coming to see you. So that holistic interdisciplinary approach at this stage, I think, is really, really important to marry the physical and the prosthetic aspects of someone's recovery to the psychosocial, the behavioral, and the idea of getting back to something hopeful and purposeful at this point in time. So, we look at this in 4 phases. So this is the 4th phase. And Tim alluded to the fact that we do have tele-rehab services. By the way, back in phase 1 and in phase 2, we generally utilize our tele-rehab services back in those areas. It doesn't require someone to come to QLI or, in my mind, go to a brick and mortar clinic to get some education, to see them in their real world, to help them, navigate and modify some of their routines. And so at really phase 2, we get brought in to do some of that training prior to the prosthetic acquisition. And again, in phase 4, this pops up again. And so because hopefully that inpatient or day program or whatever that phase 3 recovery and rehabilitation looks like, back to phase 4, they have to get back to life. And so we have been really successful in using tele-rehab to help with that transition, especially if they're coming to Omaha and they're going back to a city that's pretty far away. We can bring our expertise to them and help them along the way and see them in the real world, and reinforce all of the strategies and all of the techniques and all of the therapy that's already been done. And then as they progress, we know that that's going to happen, right? So we're only probably 6 to 8 weeks post that prosthetic at this point in time. And so they may need another prosthetic or even 2, depending on the fit and how the residual limb is responding. And so we can be proactive with that. We can make sure that there's no issues with the current one if we feel like we have a good one in place. And so having that expertise in that environment is extremely helpful. In terms of tele-rehab, why we think that's beneficial is this contextual learning component, right? So there's a lot that happens between the clinic and home. And so that's one of our main arguments why brick and mortar clinic in some ways, and more ways than what we thought would be, is at least it's at least as good as tele-rehab, but in some cases tele-rehab is superior to clinic-based care, because seeing someone interact with their home or their work environment with your own eyes, even if it is through video, can be really valuable as a clinician. We can see exactly what's going on. We can see the unpredictable aspects of their world, and then we can respond to that very, very quickly. Versus if they go to a clinic, oftentimes we depend on their self-report, and there can be some interpretation issues and challenges that are just a bit more difficult, or we can overcome them. It just might take a little longer. So not only do you have access to the experts, you have this continuum of care, but then you still have this meaningful and individualized training that is in many ways superior to what you get when they go to a clinic. There's also a convenience factor. And we're finding that with tele-rehab, this is one of the main drivers. So it could be that they are in a rural area of the country, and so access to expertise or simply getting in a car and having to drive an hour or 2 round trip is not desirable. And so tele-rehab can be a really nice option here. This is where we see the most people buy into tele-rehab. Where we see gaps is this idea that even if someone is in a more metropolitan area and you do have a clinic in that area, beyond that contextual learning, there's also this issue with going to a provider with expertise, right? And so that expertise is extremely important. And then I think this convenience and motivation component goes hand in hand with each other. Because it's convenient, people show up. And because it's convenient, they can still go to work and they can minimize lost time at work. They can minimize lost time with their family and friends, leisure time. So they're more motivated to just sign on, get their work done in whatever environment makes sense. Again, it's not just confined to the home. We encourage folks to get out into the real world. And so that's another, I would say, argument against tele-rehab that I see a lot, is that we don't want them to be confined to their home. So we want them to go to the clinic. Totally get it. We want them to be outside of their home too. And if we can do therapy outside of the home whenever possible, that's what we do. And so these individuals are very active in the real world, and they're extremely motivated and engaged in their therapy because they're doing therapy that makes sense to them. So this phase 4, like I said, just to highlight it, it helps with continuity, right? Or if you have someone who's gone through that inpatient stay, we get some requests at this point in time to help these individuals at a more outpatient level. So after this slide, we're going to go through a couple case studies. So this first case study is someone who has been through QLI's inpatient program, and then transitioned to our telerehab program. So basically phase 3 and phase 4. And so the diagnosis, as you can see here, right hand amputation, phalanx of the thumb, metacarpals in the fingers. He also had a rotator cuff repair on the same side. So not only did the person have the amputation, but there was definitely some shoulder and scapular issues that came up with this. And so it definitely impacted his recovery. So when prior to coming to QLI, he's 24 years old, lived at home, and he had a body powered prosthetic, but he was really struggling with inconsistent use of it, and really complained of the fit. So for various reasons, some of it was psychosocial, but other aspects of his situation impacted how much he actually wore his prosthetic. And so the approach that we took was a day program and the telerehab services. So some of the goals, we worked with the prosthetist to evaluate the fit of the current device. This is when I referenced that challenge that we had with the previous prosthetist. This is exactly what I was talking about. We had to spend a lot of time with that prosthetist to understand that he did a good job leading up to us, maybe not always the way that we would do it. But we don't have full access to the scenario that he was dealing with. So it wasn't meant to be conflictual, but we had to understand, and eventually we had to transition him back to this prosthetist in this case. So building a relationship right out of the gate was really important. He was recommending a new device. And so for the work comp payer, this was one of their big goals, right? They had already paid for one that he really wasn't using. And it's not, excuse me, it's not that they weren't open to purchasing another one, but they didn't want to purchase it unnecessarily. So for us, evaluating the need for that additional device was extremely important. And it impacted his outcome, but it also impacted the situation for the payer. And then regardless of the prosthesis, can we get him on a wearing schedule? Can we help him understand some functional activities that he can do? Many times what we see is people will say, you know what, I'm more functional without a prosthesis. And so if that's the case, we give permission to say like, hey, if you're more functional, you don't need a prosthesis, right? Let's work through that and the emotional component that comes with that and make good decisions. And with this particular case, we didn't get an additional prosthetic. And in lots of ways, he was very functional without his, and he really got back to his life not wearing the prosthetic, actually more than when he wore it. And we think that's okay, but not every situation is like that. And so, like I said, we helped him identify, here's a really good option for when you can use that and when you are more functional. But outside of this, maybe you think about not using that because you can do things more quickly. Some other goals. So he was a situation where he did come in on quite a few medications. So there's a pain management component. It was reframing that for him. So he was avoiding activity, avoiding going back to work, avoiding doing things. So he was spending quite a bit of time in his home. And so just psychosocially and life wise, he was not in a good spot. So we helped him see, what does that look like for you? How do we build your endurance and your strength up so that you're not in pain while you're doing it? And then how do we help explore purposeful activities and gainful employment? So this individual lived in kind of a rural town, so the options for employment weren't great. But with some exploration, he did go back to work. And then we helped as much as we could with the emotional coping and adjustment. He was definitely someone who was at a higher risk for depression. Some of his life situation prior to coming to QLI was pretty challenging. So we made some progress here, but he's the type of person that requires a pretty long-term maintenance-based program on the psychosocial side. And so we did recommend some psychology after he left, in addition to some additional therapy. So this is an example of how we utilized the phase 3 inpatient aspect to transition to phase 4. Here's another examples, and we do have some videos on this side. So Lane had a left upper extremity amputation and a left above knee amputation. So two situations that we were dealing with, and then also some nerve issues. So he was also pretty young, lived at home with his wife. By the way, while he was here, he and his wife gave birth to their first child. So that was a big part of their program. We were helping him with parenting and some of the emotional components of that, but even the physical components. How are you going to take care of your new child when you have a situation that you're having a hard time taking care of yourself? And that can be really scary for people. And this happened to be during the initial stages of COVID. So he was confined to the home. So telerehab was a pretty nice option. So he had a body powered and myoelectric prosthesis. So he's someone who did have two. And then he had an above knee prosthesis as well. So he only participated in our telerehabilitation services. So didn't come to QLI until really he was in an outpatient level and was really, really struggling. So therapy goals, completion of ADLs, just, getting clothes on and off, some stovetop meal prep. So can he do that? Our OT was highly involved in this one, in addition to PT and in addition to psychology. So can you get it even off? Do you get his prosthesis on and off? Can you do some chores? And then the emotional coping adjustment. So just to give you an idea of kind of what we did. So this video is a video that was taken by our clinician through a virtual platform. So our clinician is on the other side of the camera, not with him, but watching him and coaching him through his scenario. So we don't have any audio on this for you, but you can see Mel's like watching what he's doing. She's giving him some verbal cues, some techniques to improve it and to work through that. So with her coaching, he got to the point, they're working on buttoning and unbuttoning his pants, but he got to the point where he could do this with them actually on his body. And so this was leading up to that scenario with him. And this is a task that she broke down and worked up to for him. Oop, I froze him. Any questions that we can do while this froze?
Let's see here. We do have one that came through on the chat.
Good thing this is the second to last slide.
That's all right. Someone just asked about sometimes it helps. Kelly, again, thank you for sending the question in, but adaptive equipment along with a prosthesis.
Yeah,
kind of in conjunction with.
Yeah, absolutely. So that's, I think, the value of having a clinician on board, especially in this case, like an OT. She was able to understand, okay, what can you do with your prosthetic and with your functioning limbs, and then where do we need to add in some other adaptive devices and that sort of thing. So there's an evaluation component to it. There's a lot of problem solving that goes on too, right? And I think people think about this as a very linear process, and it's very much a bit more chaotic than that.
Absolutely.
I also think as learning goes, right, when someone learns a task, it's really hard at first. And then, as they make progress, it becomes a little easier, but then you have to push them even farther beyond that, right? So even the learning process has some peaks and valleys in it. And it's the clinician's job to understand how to push that person, how to get them where they're going, and then where to jump in and provide support for that. Back.
All right. So it does look like we have a little bit of technical difficulties on our side.
We can send those videos out to you all separately too, so I can make sure that they're in there with Tim so you can see that second video.
Definitely.
So sorry about that. We did have another question come in about the brain injury. So yeah, I mean, certainly we have chosen to use telehealth for the most complex of complex, right? So I think when people envision telehealth, they see it as a nice option for something that's pretty simple. So on the PT side, something very simple like a low back injury or post-surgery or something like that, they see it easily applicable to psychology, right? Because they're just talking. But for us, it's absolutely something that we can do with a brain injury, spinal cord injury, chronic pain, limb loss. Sometimes it does require some support of a caregiver or someone in that area, but we have folks who range from like post-concussive syndrome, mild TBI, all the way to pretty severe TBI. Similarly, with the spinal cord injury, we have individuals with incomplete injuries all the way to complete We are working with a lady right now who has a C5, I believe, Asia C injury. So we get the most complex of complex, and it does challenge our clinicians to be really effective and find ways to treat these individuals without their hands. And it can be done. So,
Yeah, so
for
you guys are doing some pretty amazing stuff over there on the
yeah, absolutely. And so for those of you who can't wrap your head around that, if you let us know, we've been allowing folks to join therapy sessions. That's the easiest way for us to show you. We can talk about it all day, but until you see it, it's kind of hard to understand. But lots of possibilities with this, regardless of the injury.
Yeah, kind of breaking down a lot of those misconceptions when people join.
Mhm.
It's easy to see. If you could bounce back to the Lane video, I believe it was Lane, and just talk about his injury or the amputation as well. Someone asked if it was a below elbow amputee.
Yes, it was a
Okay.
below elbow.
Okay. So it doesn't look like we're going to get PowerPoint popped back up here. So what I'm going to do is I am going to, Patricia, there is only audio right now. We did have our PowerPoint crash on our side, so I do apologize for that. Luckily, we were towards the end of it. The only thing you're really missing out is seeing Steve's face for his contact.
I'm going to try to get it back up here real quick.
Yeah, if he can load that back in, we'll pop it back up on the screen. While we're doing that, I'm going to go ahead and launch a poll question. So you should see a poll question pop up here. Again, make sure to answer that if you're wanting to receive your CEU certificate. So you should be seeing it on your side right now. For folks that may not be seeing it but want to, there may be a pop-up blocker issue or something on your side. Just go ahead and send us an email or type in the chat that you're not seeing it, and we'll make sure that you do get receive credit for it.
All right, I think I got it up and going here. Let's see if we can try this again.
You should be able to launch it up. I did want to give a shout out if anyone noticed on Steve's desktop, it is 10 degrees here currently in Nebraska with I think the wind chill is like 5 below. So for all of you that are in nice, sunny, warm places, we're jealous.
All right. So this is, you can see that, Tim?
Yep, got it.
All right. So this is Lane working on some lower body strategies.
And then I'm going to go ahead and exit the poll question. Give you guys another 10 seconds or so to answer that.
You can see that Mel chose the most stable chair she could find. Actually, I think that in all seriousness, I think that this is his shower chair. And so from a functional perspective, he's doing this, after a shower or within his dressing and morning routine. So you can see this is a perfect example of something that if you practice this in a clinic on a mat, he might be, capable of doing it. But then when you get home, if you didn't account for the fact that he's in a chair that maybe is a little less stable, I don't know if there were brakes or anything on it too. Obviously, if there were brakes, I'm hoping they would have used them, but this is a scenario that you could miss something, right? And this is very authentic to him. You can understand like, oh yeah, I can see how that's sliding back and forth. Can we make some adjustments there? I'm guessing the next step would be actually to go into his bathroom and see how he does it, within the setting there too. So perfect example of just the contextual training environment and how that can be wildly different than what you see in a clinic.
I will say that you did an amazing job of explaining early intervention significantly impacts coping and adjustment following LUMAS, because everyone answered it correctly. So
that's good. So we hit an objective even too.
That's right.
Got some folks don't see the poll question, Tim.
Yeah, that's right. I've got them all.
All right. So any other questions from the audience? Any other thoughts? Certainly if there's experiences that you've noticed, you can share those. If you can actually answer any additional specifics on programs, I'll do my best. I wasn't the treating clinician, but I did work pretty closely with Mel, who's our OT on both of these, and then our clinical team on the inpatient one. So
yeah, so right now it's kind of the final 5 minutes. If you have any questions, we'll go ahead and get those. Anyone asking about the certificate of completion or the CEU, there will be a follow-up email that gets sent out that has a poll or an evaluation. Just if you fill that out, you'll automatically receive the certificate of completion. We did a few folks saying they're 24 below and 34 below right now with wind chill. So
yeah, where are you guys?
Becky,
Oh, South
yeah,
Dakota.
Becky and Tina.
Oh, yeah.
You guys can keep that up that way.
Yeah,
we don't want that
we
down
don't want
here.
that. We don't want that here. Um, let's see, Anita, hopefully you got my answer to your explained pain question. If anyone is interested and didn't see that come through on the chat, again, the book that I'm familiar with is called Explained Pain. The authors are David Butler and Lorimer Mosley. As I mentioned, I just stumbled upon, it looks like an additional book called Explained Pain Supercharged. They're not cheap. The Explained Pain Supercharged is to the tune of $165. So maybe you go in on that with a couple friends of yours. But then there is also a workbook. I just ordered that as well. Haven't received it yet, so I'm eager to check that out. So
that's awesome.
I would highly recommend those as very great options for clinicians, even for case managers or adjusters who are dealing with this. It can be technical, but he does a great job of telling stories as well. The other thing I'll put in here is called Painful Yarns. This is only stories, and this is by Lorimer Mosley as well. So he does a great job of telling pretty funny stories. I think he's South African or Australian. I can't remember which one. So he does it. You can kind of hear his accent coming through and some of his cultural aspects come through. But he does a really nice job of using some personal stories and then relating it back to helping people understand why they feel what they feel. So awesome. Some nice options.
Becky did ask a question. I'm a vocational case manager. Getting work capabilities outlined by providers is difficult with client with limb loss. Is there a reason for
that? I don't know. That's it's hard to say without a little bit more context, Becky, but depending on the work capabilities, it can be challenging, right? So what I would say is sometimes we see resistance from the employer, right? So for whatever reason, they may or may not be motivated to have the person back. And so if they're less motivated, for us, like we do training and recommendations based on what we see actually in the workplace. And so if it was our inpatient program, we'd be simulating and going to the actual job. If it's the virtual component, we would virtually go to the job with them. And sometimes that's really hard, depending on who the provider, who the employer is. So if we don't have a really good handle on what the job duties are, it can be difficult. At the same time, we can simulate some of that and hopefully make some recommendations. So that's a scenario where I can see it can be challenging. But for us, we take it the extra step and actually see them in the environment. It goes back again to the contextual learning and the contextual assessment, because if you try to simulate that work, even at QLI's campus or in a clinic, you're going to miss, the noise, you're going to miss maybe the access to that environment and really understanding what's impacting and his or her ability to be successful or not. So that's the best I can get on that. Certainly reach out to me. Happy to, if you can give me some more context, I bet I can make a better comment on that. So hopefully that's what hits your point at least.
Yeah, that's what I'm saying. So wrapping up the webinar, if you guys have any questions, feel free to either reach out to QLI webinars at qliomaha.com or Steve directly. And we can, make sure to get those questions answered. Alex, I'm jealous that Orlando's 68 degrees right now. I wish it was 68 here. Yeah, Steve, if you could pop up your contact information, perfect. So you should be seeing Steve's contact on the screen. Any questions either about our inpatient program at QLI or continue telerehab, he's a great resource for you there. And yeah, Steve, thank you. It was a great presentation.
You bet. Thanks for having me.
Definitely. Be on the lookout for your follow-up email. Should be coming out this afternoon, and that'll have your evaluation in it. As well as we hope you join us next month. We're going to be doing, Dr. Snell is going to be back in the studio, and we're going to be talking about shunts. So if you enjoy his radio voice and his presentations, they're always amazing. So we hope you join us for that. And with that, I think we'll go ahead and kind of close out here. So thank you for joining us. We hope you guys have a great rest of your day and take care.